We want to welcome everyone to today's session. As we're waiting for everyone to join the webinar, just a few reminders to all that are attending. Handouts were sent to everyone in an earlier email. If you don't see those handouts, please double check. Sometimes due to our different security settings in each of our individual organizations, they might go to a separate folder, either trash or a spam folder. So please take a look for those, the handouts. Again, they were sent. If you need some assistance with anything technical, please don't hesitate to put that in the Q&A box as well. CEs is a reminder to everyone that wants, the participants that want CEs, they will be available within 7 to 10 days after the end of this webinar. So you will receive a separate email on that if you are requesting CEs. So we're just going to take a few moments here. We're going to wait until the remaining group starts loading in here into our session, and then we'll get started here. It looks like we just have a few more individuals that will be joining us here today. So we'll just take a few moments until everyone can get on the webinar here before we begin the session. Again, reminders, handouts were sent out in advance via separate email. Please check if you weren't able to see that in your email. Due to security protocols in individual organizations, it might be sitting in a spam folder or a separate folder as well. And also, just a reminder, if you are wanting to get CEs, information will be sent out within 7 to 10 days after this webinar, after the conclusion of the webinar, and instructions for your CEs will be in that email as well. If you have any questions, please don't hesitate to put that in the question and answer box as well. So I want to welcome everyone to today's session on the power of partnerships and really how partnerships are an integral part of the transformation of healthcare across the continuum. This session really is an important one for all of us leaders in healthcare. With the dynamic changes that are happening for all of us as leaders and operators, as well as consumers in healthcare today, we're hoping that the session will provide you with keen insight on strategies for success and conversation around the power of partnerships. My name here, I am Lisa Thompson. I'm the Chief Operating Officer here at Pathway Health, and I am very honored to be the moderator for this session today. Joining me here are two of my esteemed colleagues, Chris Laxton, who's an independent consultant in aging services, and Tiffany Robinson, who is the training specialist for ComForCare franchise systems. I will like to start by introducing Chris. He is a healthcare association professional with over 40 years experience in long-term care, policy, leadership, organizational performance excellence. Chris was the executive director of AMDA, which is now called PultMed, the Post-Acute Long-Term Medical Association, from 2013 until his retirement in May of 2023. He is now an independent consultant in aging and also an active volunteer in aging services quality improvement initiatives. He volunteers as the vice chair of the Center for Excellence in Assisted Living, now SEAL at UNC, a program of the University of North Carolina. He also volunteers for the Moving Forward Coalition, as well as the Advancing Excellence in Long-Term Care Collaborative and the Board of Overseers for the American Healthcare Association's Baldrige National Quality Award. He lives in Portland, Oregon, in a multi-generational household with his wife, his daughter, son-in-law, and 2 grandchildren. And also joining me today is Tiffany Robinson. Tiffany has worked for ComForCare franchise systems for 20 years and has a bachelor's in social work from Oakland University in Rochester Hills, Michigan, and has a certificate in instructional design from the University of Maryland. As ComForCare's training specialist, she works specifically with onboarding new offices and helping facilitate their training programs. I want to welcome Chris and Tiffany to today's discussion around the power of partnerships. We do have a few objectives for our session today, and some of those are looking at the value and impact of cross-sector partnerships in improving the coordination of care, knowing that partnerships really assist in reducing fragmentation across the care continuum, specifically looking today at post-acute care. And through our panelists, we will discuss key strategies to build and sustain collaborative relationships among all of us as leaders and healthcare providers and partners throughout the aging services, organizations, and community-based partners. And we will apply real-world examples of partnership-driven innovations that support really person-centered care and reduce the duplication of services and address the holistic needs of older adults. So, when we look at the value of partnerships, I want to kind of set the stage for today's conversation. We know that the healthcare system is undergoing a dramatic shift. And today's healthcare ecosystem really thrives on collaboration and partnership between various stakeholders, as we know that in this complex world of healthcare, no single entity or healthcare provider can truly provide comprehensive care across the whole patient continuum and their journey. So we'll learn more about this value of partnerships across the continuum throughout our session here today. We know that partnerships, collaboration, strategic alliances, this cross-sector collaborations and partnerships are really truly an essential component of the strategy to improve health and well-being across all sectors in healthcare. In the simplest terms, by joining forces together, our organizations and community organizations can achieve better outcomes for the individuals that we serve. There's many compelling reasons for why have a partnership or a collaboration or a strategic alliance. Some of them, and as we see here on the screen, one of the biggest reason and the ultimate goal for all of us is we want to improve care coordination. At the heart of every healthcare partnership lies this shared goal. By combining our resources and our expertise, we can offer a more comprehensive and coordinated approach to care and our services. We also know that optimizing resource allocation is very important in today's world. We're stretched thin. We know that we are stretched to the point that we know that a partnership or a collaboration or a strategic alliance will really allow for the pooling of resources and expertise, which leads to more efficient utilization of our services, our products, and what we do, as well as our personnel and the workforce that are part of our organization. We know that partnerships also expand our access to specialized services. So most healthcare organizations cannot afford full-time specialists or, for example, like advanced diagnostics. So partnerships can fill those gaps that we identify as an organization to help us to be able to provide the best services and outcomes for the individuals that we serve. And it also allows us to share our best practices and what we've learned and what we can help each other, whether it's chronic disease management, whatever it is, that we have that opportunity to learn from each other's experiences, which lead to improved quality standards and service delivery across the board. We also know that partnerships or collaborations or strategic alliances can also assist with reducing costs. And it looks at ways of streamlining our operations, reducing redundancies that we have, and leveraging really the collective bargaining power that we have between our organizations. Overall collaboration for partnerships will enhance the outcome for older adults across the continuum. So we know that collaborations or partnerships have long proven they are effective and very beneficial. So it cannot be overstated how important partnerships are. As we move towards a more collaborative future, these alliances will be instrumental in really ensuring accessibility and high quality care for all. So when we look at that, partnerships are the key link to that puzzle. It is, as we know that today's world, we don't have to do it alone. One of the most powerful strategies that we can use right now as leaders, as we're trying to figure out the dynamics of this new healthcare era and the world and the future of healthcare, it really is leveraging partnerships and collaborations that we have. When you build the right relationships, it changes everything. So let's talk about why partnerships matter so much in today's healthcare world. Whether we're managing, organizations or community-based organizations, a skilled nursing facility, assisted living, home and community-based services, home health agencies, healthcare systems, we know that our ability to work efficiently with other providers and other organizations directly impacts our patient or our resident outcomes, our regulatory compliance, as well as our financial performance. So building and maintaining those relationships are key for us. Whether we're just getting started, if you're new to partnerships or don't have partnerships right now, or strengthening what you already have, intentional collaboration is a leadership competency. It's a competitive advantage. So when we look at that, I want to have some further and deeper dive discussions about partnerships and what it means today in this collaboration. So, Chris, I want to start with you. So, based upon your vast experience and insight, could you really help us and share some light with us and some time with us today discussing the current status of healthcare, the healthcare continuum, and really your thoughts on how to build and sustain a collaborative relationship between healthcare providers or organizations?
Sure. Thank you, Lisa. I'm glad to be with you all today, and certainly the discussion around partnerships is one that I've been working on from a health policy point of view most of my career. So happy to be here. I hope this is an interactive session. If you have questions, please put them in the Q&A, and Lisa will field those to either Tiffany or myself as we go forward. So let's have that first slide, please. Yeah, so we find ourselves in a state where we love to talk about the continuum of care, but from a patient's perspective, a patient or resident's perspective, it doesn't really look like a continuum. Next slide. Really, what it looks like is a cluster, by which I mean a cluster of silos. It's a siloed system. There's all of the various elements of that you see on this slide. The cluster really has a separate regulatory framework for each of them through Medicare mostly, but also state regulations and a variety of ambulatory care regulatory requirements. Next slide. It also has all of these silos have different financing mechanisms: home care, nursing homes, AL, hospitals, et cetera, and different staffing models. And you can see the sort of staff to patient ratios are widely different depending on where you work and what the settings are. Next slide. So, we think about the patient and resident experience in terms of this smooth transition from one setting of care to another. If we, for example, take our famous resident, Mrs. Jones, who may have suffered a fall and goes to the hospital to have it evaluated and perhaps have a total hip replacement. She comes back to the nursing home for some rehab, gets discharged home with a little bit of home care, either medical home care or non-medical home care. Finds after some time that she needs a little bit more help, so she goes into assisted living and perhaps needs some memory care, and finally goes into hospice for that last walk of life. So this seems like a very smooth and ideal process for the resident, but in fact, is that's really the patient experience? Is it like this, or is it like what's shown on the next slide? Right. So kind of a tangle, a maze. We see that Mrs. Jones actually gets bounced back and forth between emergency room visits and back into perhaps rehab or skilled nursing. She may transition into long-term care. Again, other visits to the hospital because of some medication issues or perhaps another fall. And, by the time she gets to assisted living, she may be, beyond their capacity to care for her, and so on and so forth. So this is kind of actually more of a realistic picture of what we're calling the continuum from the patient's experience. Can we have the next slide? It is a chaotic process. And as we know from organizational development, chaotic processes result in systemic problems, not just for the resident and the patient and their families, but for the system that is providing, or the series of systems that are providing the care. Patients obviously are often completely overwhelmed by the complexity of the healthcare maze that they're confronted with. I'm sure you're aware of the number of families who think anything post-acute is a nursing home, whether it is or it isn't. Certainly, transitions of care have been a major problem, I would say, a challenge for good continuity of care throughout the post-acute long-term care system. Uh, we see certainly a big focus on reducing avoidable hospitalizations, and yet there are still really too high a number of hospitalizations for things that really could be handled either within the setting or by bringing in a consultant. Certainly, medication reconciliation uh, and optimization, because there's so much polypharmacy in our setting, is an issue that a lot of patients and their families confront. Infection risks, obviously, we've just been through a pandemic, but despite that, and for many, many years prior, and the infection control F-tag was one of the highest and still is probably the number one F-tag in the nursing home world. And then, of course, managing expectations for families. It's hard enough for those of us who know this setting to sort of really understand all the various ramifications of what each setting can provide and how you pay for it. For families and patients who are probably in crisis because mom or dad has had an incident that's caused them to have to change their healthcare setting, it's really really difficult. In terms of the problems for systems, Lisa, I think, rightly mentioned a number of them, but there's so much waste that really comes from our siloed system. Uh, I read a statistic recently that said something like fully one quarter, 25% of all healthcare spending in the United States is due to waste, is due to, more pharmaceutical waste, to consumable waste, and so forth. Obviously, there's lost revenue as there's certainly waste and lost, unnecessary costs represent lost revenue, but there are other forms of that as well. We see a number of adverse events and poor outcomes as a result of these silos specifically. And I think, we find that systems face higher liabilities and the potential for higher fines because they can't really manage those transitions and the continuity well. In terms of communication with systems, I think really this has to do with managing expectations between settings. Does the emergency department really know what happens in the nursing home, what their capabilities are? Do the folks in assisted living really understand how much they can take on and how much they really can't, and so forth and so on? And I think there also tends to be, because of the way things are financed, these perverse incentives for keeping people in one setting longer than they should or beyond what is really necessary for the best outcome and the best care that they have. So next slide. So yeah, I think the result of all this is kind of the long problem statement, is that we see partnerships as being a solution to a number of things. Coming up, I came up through home care into post-acute care through diabetes self-management, and then into long-term care through the nursing home world. And, I can tell you that the number of times I heard folks in home care say, we're never going to ever, put any of our people in nursing homes, and whether they need them or not, and saw them as very much competitors, and vice versa, the folks in the nursing home world who saw their colleagues in home health care as being competitors. Unfortunately, our fee-for-service reimbursement system reinforces this. It sort of provides the headwinds that kind of make collaboration difficult, which really creates a zero-sum game. If there's a winner, there's got to be a loser, and vice versa. And really, more from a sort of more moral point of view, what we see as a result of this is that human lives are commoditized. They just become heads in beds. And that phrase itself, which is one I hate, is one that you hear quite a bit because of the ways in which people think about kind of the business relationships that have to take place. So there are
Chris,
many reasons. Yeah,
Chris, can I ask you a question as it relates
please.
to when we're looking at the reimbursement and everything? And whether you on this call here, you're a private duty home care agency up to the point of being skilled nursing, or you could be acute care, you're a care management individual professional here. When I look at reimbursement and we look at the design and change, and it might be leading into your next portion here, but I look at this whole managed environment and
Hmm.
trying to make it, in some way the impression is because I think about my elderly family members who think, well, if I just have managed Medicare, it just makes it easy because I just go to one person, they take care of everything. I mean, and that's what they believe is the partnership for their experience. But yet, in fact, it's really not what's happening, right?
Yeah, no, you're exactly right, Lisa. And I think we're getting into this with my next point, which is, there are some changes in financing and reimbursement that might support more partnerships. Certainly, the
Mhm.
concept of value-based care can reinforce uh, uh, partnerships across settings, but it needs to be done right. The methodology, I think, is what's important here. We don't want value-based care to be a euphemism for cost cutting, because I think really that just essentially reduces the ability for providers to really give the best care necessary for whatever the patient needs. And, and I think to your point, there are still so many complexities across that maze of settings that we discussed just now, that if somebody needs a service or a particular kind of specialization that isn't part of that partnership, they're still dealing with essentially having to go outside of whatever that managed care process is. So I think we are still in the early stages of having those built-in silos and built-in kind of headwinds against partnership to be eroding. But I do have some hope that policymakers have an opportunity here to really look at better ways of incentivizing partnerships, because clearly it makes sense from a resident point of view, and I believe it makes sense reducing again these perverse incentives from a system point of view too. Certainly, we know that partnerships can improve patient experience by smoothing these transitions of care and making sure that there's good coordination and improve the patient outcomes as a result. We don't have so many med errors or things that are, as I say, that are avoidable. Hospitalizations are traumatic events for most frail elderly residents, and I think they're really difficult for the systems as well because of this kind of lack of understanding of, what capacities exist on both sides of that equation. Certainly, we can see lower system costs, and again, shared savings models are great if they're done right. And I think that's we've seen experiments in shared savings through Medicare that only some people can take advantage of, and other providers can't really see any shared savings. So I think there are again market differentiators here that need to be smoothed out in order for everybody to be able to take advantage of these financial partnerships. Certainly, a reduction in waste is a one of the really good benefits from a good partnership, because I think people can see that they don't need to duplicate when it comes to consumables or pharmaceuticals. And kind of at the base of it is this cross-setting understanding, which I can tell you from my own experience, we've had conversations with emergency departments where they really don't understand what a nursing home is capable of doing for them, as well as to doing with them, and vice versa. I think nursing homes, I think, are always frustrated by these cold handoffs. They're not, good transitions of care. Medications get lost or misplaced or put in at the wrong dose. People who are well on the way of reducing the use of antipsychotics, for example, suddenly find that their resident comes back to the hospital, fully drugged up on an antipsychotic again. So, these are the kinds of things that we can avoid through good partnerships, and it just begins with having good understanding across settings. Could we have the next slide? I think here we're going to begin to get into some potential opportunities, and I look at these from a population health point of view. So when you look at the long-term care population, and I see potential for partnerships with community-based care providers, such as PACE programs, certainly home care and home health come to mind. many community resources, and I see a lot of kind of visionary nursing home operators really turning their long-term care beds into community resources. That space is used, almost as a community center. Respite and adult day come to mind, home-based hospice services as well. Getting more into patient acuity here, certainly acute care and the skilled nursing world have a number of things in common when you look at patients. I've heard many times my physician members tell me, my patients are basically hospital level patients, and we're running kind of small hospitals within the nursing home. So we know that LTACs, rehab hospitals, and skilled facilities do have a very comparable patient population. Certainly, when you get into specialty SNFs, those who are focusing perhaps exclusively on things like cardiac care or respiratory care, and specialty clinics, especially like dialysis providers, those can form and are forming, I think, very productive partnerships. And more recently, we've seen the development of geriatric emergency departments. These are certified by the American College of of Emergency Physicians. Geriatric surgery units, again by the American College of Surgery. And I think these are the kinds of units, emergency departments and surgery units, that have had a really sort of natural conversation with the skilled nursing facilities in their areas. They can really understand when they're sending a patient to, for some surgery or for some emergency care. Um, they really have a better understanding of the patient population that they're dealing with. Just a funny story. We did have a conversation with the American College of Emergency Docs when I was with PulpMed, uh, where we were saying, the thing that bothers us the most are overtreated and probably overdiagnosed UTIs, urinary tract infections. And they were like surprised by that and saying, really, the thing we don't like the most is overdiagnosed and overtreated hypertension.
Oh,
And we were all shaking our heads and saying, really, that's not an issue for us. And they're saying, yes, it should be. It's an issue for us. So, these are the kinds of conversations that I think can be very, very helpful. Could we have the next slide, please? So a couple more before we get into the conversation. But I see again, community-based models and assisted living can also, I think, have some very good synergies. Senior housing with services, certainly the independent living portion, say, of a CCRC or of an AL community. Assisted living itself, certainly memory care, which is kind of lumped together with AL, but of course, it's really a much more high intensity a setting of care for the residents there living with dementia. Active aging communities and 50 plus communities. Again, another funny story. When I was working with the Leading Age affiliate in Illinois, which was also the at that time Argentum affiliate, I thought to myself, all those active aging communities, the Del Webs and so forth, are dealing with folks who are, getting up in age and they're dealing with a few chronic conditions. And so I had a conversation with a couple of them, and they were like, don't talk to us about nursing homes. It's like, we're not talking to you about nursing homes. We're just saying your folks are eventually going to want to transition somewhere. Shouldn't you be thinking about having a relationship with your local ALs or your local, CCRCs or nursing homes? And they were like, no, we don't want anything to do with you people. Again, it's just the siloed mentality that these folks had, that, in the end, they're going to need some way of helping the people who live in these communities to transition to some other form of help. And hopefully that's, again, beginning to soften a bit. But then there are all these other interesting models, the naturally occurring retirement communities or NORCs, the village model, co-housing models. These are all sort of considered alternatives to nursing homes. And I think when those are popping up in a local community, nursing homes and ALs should really support that and be in good, solid communication with them on ways in which they can help, or find ways of being in relationship if a resident really needs more assistance than they're getting from these alternative settings. I use the example from Veterans Health because it's a huge population and a closed system. And so they're already doing interesting things around partnerships. They can't build enough nursing homes for their own veterans. And so they've reached out and grown partnerships across the community for both nursing home care, medical foster homes, and home-based primary care. These are all, to me, sort of interesting examples of a system that really understands that its own capacities, can be enhanced through a partnership model. Next slide, please. So I come from the professional association world, and so one of the things I always did with my members was to say, please reach out to your local folks in other professional societies. Most national organizations, of course, do have chapters or affiliates at the state level and local level. A number of them are listed here that you see, and I'm sure they're all familiar acronyms to you. Um, but I find that there are very few of these that are being established. And when they are established, they're usually very productive. If nothing else, just for consciousness raising and having folks understand where they come from and what they can do for each other. I would be remiss if I didn't mention the QIN QIOs, which are sort of, to me, an underused resource. These are Medicare funded quality improvement organizations and networks. And they're always available to be of assistance in terms of offering best practices, doing education, and really helping with other resources. Next slide. Yeah, so how do you start? And I think, Lisa, we can talk a bit about this. If you don't have existing relationships, it doesn't mean that you need to set up a huge legal infrastructure as a beginning point. It's really more about meeting with people. Who are the people in your local settings that touch your patient population in some way? I always encourage folks, if they're not already, to look into your local emergency preparedness networks. Every community has one, and they generally tend to be all of the sort of players that deal with emergency preparedness issues, whether it's hurricanes, fires, pandemics, etc. These are agencies that really come together in ways that are going to be helpful to residents and patients, as well as the providers who serve them. And really, the point of these reach outs is just to invite mutual awareness, cultural differences that exist between the settings, as we've discussed, staffing differences, understanding capacity and where capacity limitations are, and really sort of saying, what are your key challenges? And here are our key challenges, and are there ways in which we can work together to mitigate or address these challenges? I think that's a good way to think about starting. And even if it isn't, if you've got sort of established partnerships do take some nurturing and putting in the time to reach out and meet with people, to just sort of give them updates on where you are and kind of what you're um, what you're facing at the moment is a good thing to do. I think that might be the end of my presentation, Lisa.
And Chris, I want to leverage a little bit more about that because I think of this, and there's some here on this webinar here today have had some really long-term established partnerships that there is opportunities to grow those and change it based upon, you have to be, in today's world, we know you have to be agile. You have to respond to what the needs are, what the consumers are wanting and needing, as well as what's happening within your healthcare marketplace and the overall market geographic area that you have. And you brought up some really good points here, Chris. You could either be a very established partnerships, or if you're starting, where do you start? It doesn't have to be significant, large, like you said, doesn't have to be this huge legal entity, but to your point, like you said, start small. So it's looking at that business model that you have, right,
Mm.
Chris? And your
Yeah, it
mission of
is.
your organization.
It is, and I think a place to start is internal, to really sort of look at where are your soft spots, where are the things that you think you could really grow into more, or more particularly, what are the pain points? What are the things that really are, kind of endlessly challenging to you? And I think after having established what those are, it may be helpful for you to say, well, rather than growing that capacity within our organization, it may be more efficient and better for both the organization and the resident to do things in partnership, to see where the other entities are within your local world, who could fill that gap for you, and just begin having those conversations that way. As I say, established partnerships don't necessarily mean that you don't do that either, because conditions change, people come and go.
Mhm.
You kind of have to start over sometimes. And also, I think I like to say, once the contract is signed, that's the beginning of the partnership. That's not the end of it. It's not a one and done thing. It is an ongoing relationship, and it's one that I think yields great benefits when it's nurtured, and when I think when there's a clear and open line of communication.
And then when you have that clear and open line communication is kind of setting what your mutual goals are, right, Chris? And then, how do we determine, are we meeting and achieving those goals?
Oh yeah, no, I mean, now you're talking about process stuff, and I think
Yeah.
we could all sort of nerd out a bit on it. But really, in the end, I think, of course, if it's not measured, you really won't know. If you don't really know what success looks like, it's hard to know when you get there. And truthfully, there's so much overlap between many settings, and I don't think that's going to stop. It's really important to make decisions about who does what, and kind of where one partner might, hand off, and where another might decide not to. And these are not, hard and fast rules either. I would say
Right.
the regional variations in healthcare settings are huge, and I think it's really important to recognize the local nature of productive partnerships. You may have scale across the country, but within each of your regions, you know this, Lisa, from your work,
Mhm.
there's going to be different qualities and different kinds of cultural requirements that need to be met.
Right, exactly. And to the point, to all of us here on the call, is that collaboration and partnerships is key. I mean, all of us are stretched thin with our workforce. We're stretched thin with our ability to really expand beyond the scope, because oftentimes we might be taking care of someone, whether we're a home care agency, private duty agency, all the way up to health system. We might not have some of that subject matter expertise or that next level that we are requiring in order to provide all the services that we need for that consumer, that patient, that customer, that resident that we're working with. And it's very key for us to say we can't do it alone in today's healthcare world. Doing it together is better. And then when you start doing that, naturally, innately, communication will continue and will be fostered. Yes, like Chris talked about, there are some strategies reimbursement wise that are coming up that we're hoping policy wise will help us and initiate that. But also innately, all of us as leaders, we're in healthcare because we want to take care of people. We're human beings taking care of human beings. Always call it the H to H business. Yes, we're B to B, B to C, C to B, however you want to look at from a business model. But at the end of the day, we're H to H. And our journey starts here, working together, all of us together on this call, a collaborative, as we move forward here to how can we better provide the outcomes for the individuals that we serve, no matter what our provider setting is. And the core essence of this comes around and really truly comes around what I look at is then our training approaches. We can establish a model, we can look at things, but now it comes into how do we look at it, be innovative, and take that model. We start those conversations, we look at our potential gaps, we look at the model that we want to do, our overall goals, mutually coming together as organizations or in two organizations, however, that collaboration, alliance, or strategic partnership will be. But the foundational approach comes to how do we educate and train, communicate, and moving forward here. So Tiffany, I would love for you to talk about some of your real life experiences and some of the approaches that you've utilized when looking at this and collaboration and partnerships in the healthcare continuum.
I would love to. Let's talk about training approaches with partnerships in mind. We want to foster a culture of training collaboration. We want to take a focus on equipped individuals with the knowledge and skills to provide care that is tailored to their patients' unique needs and preferences. Gone are the days of one size fits all model. Today, we have to prioritize our clients' values, choices, and goals. When working with a team of professionals from multiple disciplines, we truly have to come together to meet the patient's full spectrum of needs. We must become partners in care. We want to promote shared ownership of person centered care across all disciplines. Everyone owns a piece of the puzzle, and everyone is needed to collaborate and create a training culture that works together. Co-develop training with input from staff, families, and care partners. Even after training is created, keep these lines of communication open so we can keep growing the training program to meet the growing needs of patients. Rarely is a training perfect from day one. Be open to ongoing surveillance and updating of your training programs. Align training content with the values and goals of patients. We want to encourage our team to always look at ways to personalize the care that they provide to patients. When working with your team and other teams that are involved in caring for the same patients, use real life scenarios to drive engagement and practical application by making learning more relatable, hands on, and more impactful. Consider utilizing role playing and simulations for these training sessions. Reinforce learning through continuous feedback, mentorship, and coaching. Think about providing supervisory visits to check in and see how care is being provided and offer feedback. If someone needs additional support, provide some on the spot coaching through a skill or process. Also, offering mentorship programs to allow more experienced staff to help grow and support lesser experienced staff. Next slide, please. Training with collaborative partners. We want to foster alignment by sharing core training with partners like home health, OT, PT, hospice. Consider group training, joining forces, and creating training that connects everyone together and encourages communication and collaboration. Use joint training to clarify roles, reduce duplication, and enhance communication. We are always using our training to help our staff be more efficient, to provide them with a clear understanding of who is responsible for what role or process. How do we work together? How do we share what is going well? And how do we share concerns along the way? These are all important questions to consider as we are working together. Leverage technology. Do not be afraid to venture into the virtual world. E-learning can have huge benefits for your team. It allows training to be provided at your staff's fingertips. It can be available to them 24 hours a day. Blended learning is also something that can be beneficial when working with multiple teams. It takes the in-person training and the virtual training and puts them together, presenting some topics in person while allowing other topics to be covered in a virtual element. Even after initial training is created and things are running smoothly, still make sure you are having collaborative sessions. Bring everyone together ongoing for check-ins and aligning of goals. Promote a unified care approach. Let's work together. Let's keep communication going so we reduce duplicate work and tasks. Next slide, please. Now, what I'd like to do is review an example of a training plan in action that has collaboration. In the example I want to share today, we are looking at a home care agency collaborating with an assisted living facility. We had an office who had an opportunity to work side by side with an assisted living facility, providing additional services to their residents. We were able to offer, at an extra cost to patients who opted in, more one-on-one services than the assisted living was able to provide in their scope of care. This would help the assisted living keep the residents that needed or wanted additional care that the facility was not able to provide with their staffing. The facility really wanted to make sure that this relationship was seamless. We needed to collaborate on the needs, conditions, and overall goals of the patients in this facility. A few things that we learned by having our training lead meet with their leadership and training lead is that many, if not all of their patients had regular mobility issues, including many patients who were bedbound. Many patients also suffered from depression as a result of losing abilities that they used to have, such as their mobility or things from other diagnoses. It was imperative that our caregivers had training and knowledge on working one on one with clients with very limited mobility. We created a training plan together that included many courses in our learning management system, such as bathing a bedbound patient, shampooing hair of a bedbound patient, working with clients with limited mobility, working through the emotional side of caregiving, in addition to training that discussed the collaborative relationship that the facility would be providing care in. It was important that the facility staff and our agency staff were knowledgeable and understanding of our shared efforts. What care is being provided regularly by the facility staff? What care will the agency staff provide? And so forth. It was also important to gather feedback ongoing from the facility staff and leadership, patients and their families, as well as our agency staff, keeping the lines of communication open and making an asserted effort to make sure we're answering questions, concerns, and complaints in a very timely manner. This is something that we're making a priority. We also learned that the facility had gone through some budget cuts, which took away some key programs that encouraged movement and mobility with their patients. It was also brought to our attention that many of the family members did not have a clear understanding of having loved ones with limited mobility and how to best encourage and support their loved ones. We decided that in addition to the education provided to our caregiving staff, we were also going to provide some simple exercise classes at the facility, such as chair rise exercises. We also created family seminars to provide education to family members to help aid in encouragement and understanding of their loved one's condition, their limitations, realistic goals. The training provided to our caregivers, as well as the joint training sessions completed with the facility staff, proved to be beneficial to our care team. The simple exercise programs and family seminars that we provided clients with the ability to work on movement goals and allowed family members to better understand their loved one's overall condition, including the emotional toll that can come from limited mobility and other conditions. Overall, the training was provided by taking courses in our learning management system, so virtually, along with some in-person sessions that included the partnership with the facility and their agency staff. We tested skills and maintained our level of care being provided by having our lead trainer provide pop-in or supervisory visits. We also continuously asked for feedback from all involved, always ready to adjust and update the training process as needs arose. In our example here today, long term, this office is now in year 5 of working in this facility. They attribute the success to the training and support that they brought in and they've maintained from day one. Lisa, I'm going to go ahead and hand it back over to you.
Well, thank you, Tiffany. And I wanted to share a little personal insight on what you were saying. Just your example really resonated to me. A few years back here, and it wasn't, I should say, recent back here. A family member of mine was discharged from the hospital with home health coming in, and as well as we were looking at some other type of level of care for. It was an older adult in my family. And I have to tell you, the collaboration that happened between the partnership, between the providers, and what they needed to do to help us. Now, get this, from a family, we're in healthcare, all of us are in healthcare, and I have sisters, that are RNs, myself from my background, everything else. But when it's your loved one and you're in that situation, it's a whole different situation. And what they did is their collaborative approach, the communication, how we went through that journey, and then the training, to your point, that real life example of training and what they provided for training, not only for us, but for the other caregivers that were going to be involved, because it wasn't just home health, it was other levels that we had to have as we were transitioning to new level of care, was very important. So you're absolutely right. In all the portions of this journey, as we look at partnerships and collaborations, training is one step of that journey, but how important it is that it provides that foundation for good outcomes and better outcomes for each step of that collaboration and journey. When we look at the gaps and we look at the opportunities to increase our skills and our competencies, absolutely very important. So thank you so much for sharing that, Tiffany, and for sharing some key insights for us. And by the way, we as a family member also had access to a specific portal on their LMS for additional backup training, just in case, because, a lot of communication came to us when we were learning all this new medical equipment and everything that we had to work with, that we had something to be able to go back to. So thank you for bringing up those different areas and levels of education and training, and how important that is when we're looking at collaboration. Because at the end of the day here, we all know partnerships, strategic relationships, or our whatever the collaborative environment is going to be, they're key to our successful outcomes. Our healthcare system is more connected than ever, however, oftentimes is more siloed than ever, as like Chris indicated earlier in his conversations. And the important part of this is that we know that individuals that we serve move across the continuum in a very quick pace between hospitals, if they're going home, or skilled nursing facilities, clinics, whatever it is. Every handoff is a moment of risk. And when we all work together as leaders and collaborate together between our entities and our specialties, and when we work together instead of in silos, the people that we serve are safer, the care is smoother, and outcomes improve. We know that everyone, when you have a partnership or a collaboration, the ultimate goal is that we are working together for the same goals. It's quality, safety, and ultimately our patient or our resident satisfaction. And it supports that shared accountability across outcomes, such as like Chris talked about, readmissions or infection prevention. So it ensures and works with us to have better, safe care transitions and keeps that care connected. We also know that as leaders, it will help us fill those gaps when we are stretched thin on our workforce, or stretched thin on, we might have enough team members, but we might not have some of the competencies, such as what Tiffany was talking about from a training perspective, that we have, that when working together with a partner, we'll be able to fill some of those gaps while we align those resources and we foster that innovation and our training together. Because no matter what, when we do that and we share our knowledge and our tools and resources, we will provide and have better care and better outcomes for the individuals that we serve. In order for us to really to thrive, not just survive, we as leaders and healthcare providers, overall, we need to shift our focus from operating in our individual organizations or in isolation, rather to building those strategic partnerships, because they are powerful. They aren't about giving up control. Partnerships are not about giving up control. They're about expanding our impact as healthcare leaders, providers, and clinicians. So be proactive, selective, and purposeful in building your alliances that improve care, that stabilize your workforce, and really strengthen your organization's overall outcomes and reputations. Start small to grow big. The importance of partnerships in healthcare cannot be overstated. And as we move towards a more collaborative future, these strategic alliances will be instrumental in ensuring accessible and high quality care for all. Because by working together, our various stakeholders, we can create a more efficient, innovative, and really patient-centered healthcare system that delivers better outcomes for all. So having a collaborative approach, leveraging partnerships, knowing that we can't do it alone, is really key to our success and moving towards the future here. So as we look at this and we end up our session here today, I want to remind everyone here that you have access to our esteemed colleagues here. We had some great insight from Chris as he walked us through where a healthcare continuum is today, where it can be in the future, where the potential gaps are, and the opportunities that we can use and leverage together to build a better future. And also the keen insights that Chris and Tiffany brought together here for us is how we create those partnerships and we collaborate together. And Tiffany, again, thank you for that solid background of looking at the key essence to everything that we do is learning from each other, innovating, and training is key to success. So we want to thank everyone for joining us here today. I'm looking here to see if we have any additional questions. And right now, I am not seeing any specific questions. So if you do have questions, please feel free to add them into the chat box. We'll answer them post-webinar. And again, thank you all for being here together and today, because no matter what, working together is key to success for the future. A reminder to everyone, the handouts, if you did not receive the handouts, they were sent in a separate email. If you need to receive those handouts, please put them quickly here into the Q&A box and we'll get that taken care of. And as well as then anybody who is looking for CEs, that information will come out within the next 7 to 10 days. Look for an email and also make sure, because of security issues on all of our information technology systems, make sure that you look at your spam boxes as well. So again, thank you everyone for joining us, and we really appreciate your input and your insight. And thank you all for doing what you do, providing the best and being those great partners in care for the individuals that we serve every day across the United States. Thank you for joining us, and thank you, Chris and Tiffany.